Welcome to Oh the Humanities, a podcast produced by the University of New England Center for Global Humanities. Our conversations are devoted to shining a light on the important work being done in the humanities at UNE and other colleges across the U.S. and around the world. My name is Josh Pahigian, and I'm your host. Our guest today is political scientist Sara Rushing. Sara serves as professor of political science at Montana State University. She's joining us remotely today from Santa Barbara, California, in advance of an upcoming lecture she'll present at the University of New England Center for Global Humanities. Sara's recent book, The Virtues of Vulnerability, Humility, Autonomy, and Citizen Subjectivity, explores how our experiences as patients within modern healthcare systems affect our understanding of ourselves as citizens able or not able to navigate the complex power and knowledge dynamics associated with mainstream medicine. And we'll get around to talking about that. But first, let's welcome our guest. Sara, thank you for joining us on Oh the Humanities.
Thank you so much for having me. It's a pleasure to get to talk to you today.
We really appreciate it, and we're looking forward to your talk. Sara, a term underlying much of your work is health libertarianism. And for listeners out there who might not be familiar with that term, I was wondering if you could just tell listeners generally what that's all about.
Yeah, so health libertarianism is a term that I've seen in circulation very minimally in the literature on what we would otherwise think of and has traditionally been called medical freedom activism. So there's lots of health freedom movements that we can think of over the past, centuries really in the United States. But I want to kind of tweak that by drawing on this term health libertarianism. And so taking the concept of freedom and medical freedom and parsing it out much more clearly. And so libertarianism as a kind of political ideology and increasingly political ethos in the United States that pervades, vastly across the political spectrum, whereas it used to be kind of an outlier. Libertarianism is, this idea that we are most free when no one gets in our way. We are an autonomous individual working our way in the world without obstacles. And the self-sufficiency is sort of a preeminent value, and the threat of government oppression is the preeminent fear. And so libertarianism has many overlaps with liberalism and some with conservatism, but it really takes the state as a problem to be managed. And so as little as the state can do as possible, that kind of conduces to our being more free. And so I'm really interested in how libertarianism as an ethos comes to infiltrate health freedom movements or medical freedom movements, which in the way I'm thinking about it, have traditionally taken their bearings from the medical problem or question that any person or movement is focused on. And the state becomes sort of a subsequent concern. And with health libertarianism, I'm trying to tweak that and say, I think that what we're seeing is people for whom the state or government overreach is their primary concern, and health becomes one domain that they take that project to.
So let's talk a little bit about your book, The Virtues of Vulnerability. In the book, you focus on three areas primarily: giving birth, managing death, and veterans with PTSD seeking care within the VA health complex. And I was wondering, I'd like to discuss each of those areas, I guess, in turn, and I'll tell you why they're particularly interesting to me from where I sit here at the University of New England. As a university, one of our greatest strengths is our flourishing program offerings in the health sciences. So those areas of caregiving, managing birth, death, mental health, are areas where we envision many of our students ultimately landing professionally. So I think it'd be really interesting for them to hear you expand a little bit on how that health libertarian ethos that you describe affects those areas. So what can you tell us about birth? How do we think of ourselves as a birthing patient? How do we experience birth, and how much autonomy do we have in that setting to start?
Yeah, so it's a great question. So birth is obviously how we all start life, and it's how I sort of came to this project in thinking about my own experiences with childbirth. I had not previously had a highly medicalized life, probably because I'm pretty lucky. And so birth was the first time I had to consider, how do I want to do this? This is this deeply intimate experience I'll probably do once, twice, now I've done it 3 times. And, but the first time I thought, if this is it, what do I want out of it? And I was going through birth training with a very close friend of mine who was a midwife, and she was very clear about the fact that she would never set foot in a hospital under any conditions if she could avoid it. And I found that really interesting. She wasn't hubristic. She just had a deeper knowledge and trust in her body. And I felt pulled a little bit in that direction. I also felt like I don't think that's right for me the first time around. I was going to have my first baby in August. I could just picture all the windows in my house opening and me screaming my head off and my neighbors not knowing what I was like, this is too much. So I opted to have my first child at the hospital, and all things considered, it was a perfectly fine experience. And I was very attuned to these subtle ways. I became a very obedient patient because I'm a good girl, and I walked in with my arm out, ready for my IV to go in, even though I didn't want an IV port, but it was the protocol. And so I saw all these ways in which I very subtly was disciplined or disciplined myself. And it wasn't, for many people, it wouldn't have been something they gave a second thought to, or maybe it would have made them feel safe. My whole approach to, the medical industrial complex is if that's where you feel safest and you have a good experience, awesome. It just, the data shows that that's not the case for so many people. And we don't talk about it in the way I wanted to talk about it. So for me, birth was that experience. It was perfectly fine. And I didn't want to go back to the hospital for subsequent children. So I had 2 home birth experiences. And that provided the point of comparison for me to think about what it means to be sort of a birthing subject, right? And what really struck me about that experience was this shift we've seen in medicine, which I sort of vaguely understood and now understand much more, from benevolent paternalism framework for thinking about the role between doctors and patients to a patient autonomy framework. And patient autonomy is a good improvement on how doctors and patients interact with each other and how hospitals regard patients. I think that's autonomy matters. And I also was struck by how sort of thin a conception of autonomy was at work. So it was really, you are free to pick between these 2 choices that we have sanctioned. And in picking between the 2 choices, you have made a choice, and therefore you have control over the situation. So you're free. You have autonomy. And I thought, well, that to most people doesn't feel like autonomy. And if they come away from a medical experience feeling that they were listened to and that everything went well, they might, again, never give it another thought. But particularly in the context of childbirth, in the 2008, 2009, I believe the numbers have now dropped, but at the peak, we had about 35% of women in the United States having C-sections. And most of those were not desired. It was either an emergency, and I'm putting that in air quotes, not because there aren't bona fide emergencies, but many times people come away thinking they had an emergency. And when they dig a little deeper, they realize, well, I'm not sure that had to happen. It turns out there was maybe a shift change underway and there was a doctor kind of ready to go, or people were very compassionately thinking, I was exhausted and trying to help me, but I wish that hadn't happened. There's all sorts of factors that, inform that statistic. But many women I knew who thought of themselves as organized and made good choices and had control walked away thinking, I don't know what just happened. Like, I think I consented that, but I don't really know what that version of consent means. And so I became very interested in that question. When people walk away from the medical, legal, industrial complex, as I think of the mainstream hospital today, or what Wendy Simons, the sociologist, has called Hospital Land USA, when they come away and they think, I don't really know what happened, that experience fascinated me. And I think childbirth is a very clear domain in which to explore it. But I then went on to think about other places in medicine where people had kind of clear paths to exit mainstream medicine and to explore what that exit looked like.
And at the absolute other end of the spectrum, what can you tell us about how we experience and how families experience death of a loved one? How much autonomy do we have in that setting? I remember back to my much earlier days, the news stories around like managed death. I believe it was Jack Kevorkian was the doctor who had tried to make that available to patients who were suffering and wanted to end their lives, but that was very controversial. But I'm sure there's much more wrapped into it than that. For the typical person, how much freedom do they experience, and how much do they relinquish in the final days and weeks of their lives?
Right. I mean, death is such an interesting context because it's really doesn't feel like there's any choice in it for anybody. And for most people who are cognizant of the fact that they're going to die, none of those choices are good choices. And so I really honed in on people with terminal illness for whom hospice would be an option. And I looked at the tensions in the medical, industrial, legal context again about like whether that's treated as a good choice, right? And so how we think about hospice in the United States. I will say, I think that, in the last 10 years, even in the last couple of years since I wrote this book, I think that context has changed some. Maybe with baby boomers coming to face their demise and realizing that they want more choice in it than they thought they would. But what struck me about the context of death and dying in hospice when I was working on the book was that, so few people are able to draw on it for a particular length of time, largely because doctors go into fight mode, and want to really not give up, right? Not abandon hope. And also, not, for some doctors will say not fail at saving a person. And so sitting down and saying, let's take a step back, let's acknowledge that you're going to die, even though that's really scary. And let's talk about the best death you can have and how you can have quality time until that death. That isn't something most doctors get any training in. It's time spent that they don't get paid for. It's emotional labor that takes a big toll. And so it's just a context where, we have these options for better ways of dying. And better, I mean, like, if you are, have had cancer for 6 years and you end up dying in the ICU, being intubated with someone trying to save your life, that's not a good death. It's not a good death for the person dying. And it turns out to be a terrible death for their family members, right? So we have these better options. And I was really struck by how little we use them. Having said that, I just watched my 80-year-old dad die of stage 4 lung cancer in 2 weeks, and he had advancing dementia. And so it was never going to be a choice for him to use physician aid in dying, which is, Dr. Death, Jack Kevorkian, what we used to call assisted suicide and now refer to as physician aid in dying. That was never going to be an option for my dad. He did have really wonderful hospice care. But he only had it for about, 2 weeks, which is much longer than the average person. But I feel like I've seen kind of another side of it. It hasn't changed my thinking on it, but I do recognize that like there are lots of places where we don't allow that choice, and maybe that's appropriate. For a person who is suffering from dementia, or for children, for other people who can't sort of understand the broader context, we do, I think, it appropriately protect them from abuse and that, potential abuse in that way. But I also just, watched the state of Montana vet a bill on physician aid in dying. And we are one of the states in which that has traditionally been legal by some kind of a decriminalized loophole. And the Republicans in our state are trying to close that loophole and make it illegal. And so I sat through a lot of the testimony I watched, online as they were testifying in the Senate Judiciary Committee in Montana. And I was struck all over again by how kind of thin our discourse on it is, and how kind of just unsophisticated we are as a society when we think about death and dying. So we have a long way to go. But my stake in that was sort of, what does it look like to have choice and control in a context where you would never choose that and nobody feels like they have control?
Mm. And how about mental health? How do these dynamics come into play in that domain?
Yeah, so if the kind of exit context for birth is home birth and the exit context for death and dying is hospice, in the context of veterans with PTSD, I was really struck by how many of them wanted choices that were not sanctioned within the traditional VA framework. And, in particular, I look at sort of what they think of as sort of natural healing. So the use of yoga, the use of medical marijuana, other kind of psychedelics for treatment. Things that were not, heavy-handed pharmaceuticals or mandated treatments in a mental health facility that took, hours of waiting. And I will say this isn't a knock against the VA. As I look at our government kind of gutting all our social safety net, I will say veterans, much as they get frustrated with VA healthcare, they do not want it to go away. It is our only socialized medical system in the United States. And in general, people are very grateful to have it. They just want it to work better. But in the context of navigating PTSD, and particularly after our, long war in North Africa and the Middle East, we just have seen people who say there have to be other ways of doing this. I'm so medicated, I'm not feeling any better, and I'm waiting in long lines, and I'm just, I'm sort of stuck in this zone. I want to try something else. And then, in the veteran context, of course, these are federal government doctors and facilities, and so they're really bound by certain laws. And so particularly medical marijuana has been a sticking point. This has obviously changed dramatically in the last couple of years as marijuana is legal in many states. Still hasn't made as much progress in the context of VA mental health care or federal research on the effects of marijuana. But I do think that culture shift is happening before our eyes. But so that was my interest there, sort of, how do we think about people having choice and control over treating their own mental health when you're in a context where everything has to be data driven and none of that data can be collected?
So you've described how receiving healthcare in these various contexts infringes on our personal autonomy, leaves us vulnerable. In the book, you go so far as to use the word as sometimes receiving care humiliates us. And I was wondering if you could expand just a bit on that idea, that there's something almost demeaning about the power dynamics sometimes.
Yeah. So, I mean, the kind of main premise, I think, of that book and of the Health Libertarianism Project and my general work on kind of body politics is that the body is a problem in Western political thought, right? Where bodies fail, which they inevitably do, that is a source of sort of shame and humiliation. And we can think about all the ways in which, non-normative bodies are the sources of shame. Everything from fat people to disabled people to, right? I mean, just the accident of being not white, right? I mean, there are all these ways that bodies are the source of or site of shame and humiliation. And part of what I wanted to explore, and again, this really came out of my experience with childbirth, is in what way can we shift from a framework where bodies are the source of humiliation to a framework where we could cultivate a certain humility at the level of the body that allowed dependence or interdependence with others to be a source of strength. And so that was kind of the question of what does it mean to be a health citizen? What does it mean to have autonomy and agency in a health context? And it can't just be, here's my list, here's how it's going to go, because bodies are very unpredictable and that rarely works out well. So I really looked at wanting to move away from autonomy, autonomy is total freedom and self-determination to a relational conception, and away from a conception of bodies as humiliating to a conception of bodies as a source of humility. Because in my account, humility, when we can separate it from its traditional, religious context, which, I know a lot of, Christian philosophical scholars who will say humility is really an empowering virtue. And I'm like, that's great. I really want you to make it so. But, when I see it come up in the Bible, it's like not often in an empowering context. It's really sort of like bow down before me. And, that is one conception of authority, but it's not the only conception. And so the humility that I wanted to articulate, coming from kind of a more Confucian context, which was a tradition I got the opportunity to study in depth 15 years ago, and really gave me a new understanding of humility as a relational kind of root virtue for all the others, sort of says that humility can really be the source of humor about ourselves, right? Like if we, you wipe out on the ice, you live in Maine, I live in Montana, we wipe out on the ice. I do it at least once a year. And if I go down and I think, look away, everybody, look away, it's horrible, don't look, then that's awful. But if I laugh, pick myself up, usually people turn and laugh with me, and we all share that experience because we all wipe out on the ice, and it becomes a point of contact. It becomes a kind of a point of thinking, this is just what it is to be human. And I think that that's more genuinely empowering than denying that we are, humble in all our ways as we live our lives in bodies that fall on ice. So that's kind of what I wanted to do with that idea.
So I haven't fallen on the ice yet this winter, and I'm hoping this conversation hasn't jinxed me. But when I do, when I inevitably do, I'm going to try to think about it a little bit differently now that I've heard you explain how we can kind of reframe that view of ourselves in the moment. Shifting gears just a little bit here. Your current research examines the medical freedom movement, which has grown increasingly robust in the wake of the COVID-19 pandemic and the associated mask and vaccine requirements or mandates and the ensuing battles around them. I'm wondering, looking through your lens as a political theorist, how do you see this movement, and what can you tell us to help us understand its growing momentum? Is this just a cultural moment that we're in, and as the COVID experience fades into the rear view of our life stories, will that momentum fade, do you think, or has it sparked a movement that's just going to keep gaining momentum?
I mean, that's a great question. About 6 months ago, when I was starting to work on this project more deeply, I thought, I wonder if this is passé. And then Trump got reelected, and RFK Jr. got appointed, head of the Department of Health, and I don't think it's passé at all, sadly. Which is why I've shifted from saying, COVID to viral times. Right? There's something about COVID times that I think is not going away, maybe ever, but definitely not anytime soon. I think. As a political theorist, I tend to think about bodies and embodiment, and that's as, a feminist and democratic theorist. But I also think very much in terms of this classic concept in political theory of the body politic. And I think our body politic is sick in all these ways. The viral times are going to stick with us. So I think that, when I was writing the book and I was giving talks on the book, and people, inevitably would ask me, not inevitably, I did not actually fully anticipate this question, but when I started giving talks, I thought, oh, wow, this is coming up every time. People said, it seems like you think home birth and hospice and, sort of like alternative remedies for veterans are sort of admirable kind of acts of health citizenship on the part of the individuals who make this choice to sort of exit the mainstream medical complex and pursue these alternatives. And I said, yeah, I think I do. I do. I'm not denying that there's like an axe to grind here, right? I think this is something we all should kind of consider. And then people say, well, what do you think about anti-vaxxers? And this was around COVID. What do you think about anti-maskers? And so I really had to think about sort of what was the distinction there for me. Why did I think one was, could be framed as a kind of laudable act of health, citizenships, health activism, and the other as potentially really problematic? And so a huge part of that comes down to, when medical freedom movements are attacking public health versus when they're advocating for private choices, right? And I don't think the private and the public are neatly distinct at all. I think that's a bit of a false dichotomy, but I do think there's a difference between saying I want to have a home birth or I want to opt out of, curative care and go into hospice, and saying I don't want to get vaccinated against, a viral disease because I don't want to. I don't like it. No one's going to tell me what to do. It's my body, my choice, which of course is a traditional feminist rallying cry and has been co-opted in really interesting ways. And so for me, the distinction came down to sort of public versus private and what is only self-affecting and what affects others. But I don't think that tension is going to go away anytime soon. I mean, as we're talking, we're at about, over 160 people who have the measles. We're not calling it an epidemic yet, but I don't, I'm sure epidemiologists have a sense of when those scales tip. And it's not just this little West Texas town now. It has gone into New Mexico. As of yesterday, there was a case in Florida. And of course, it's about to be spring break. So, where were we in January 2020, February 2020? We were kind of naively thinking that COVID was about other people and other places. And then it became a global pandemic. Do I think measles is going to become a global pandemic? I mean, I don't, but probably only because I'm naive. So I think that these kind of viral times are with us, and medical freedom movements are alive and well. And I do think because of the viral times, they may change in certain ways. And maybe they will become more rigid. Maybe they will become less rigid. And of course, they're not only about, vaccines. I mean, vaccines are the ones we've looked at for a long time in the United States because they had kind of maybe a politically neutral, but maybe a slightly left-leaning origin in kind of the natural health movement. And now they've become very, very much more a right-leaning movement. But I think medical freedom goes back through our history a long way to what was originally called therapeutic freedom. Everything about medical licensing, should doctors have to be licensed or not, which strikes us as like a crazy question, but was a very prominent and very successful movement prior to the Civil War. And everything today from should vitamins be regulated, should GMO labeling be extensive, the National Health Freedom Congress, National Health Freedom Movement wants to see natural immune system education introduced into all schools. RFK did just 2 days ago talk about cod liver oil and vitamin A as viable ways of combating measles. So I think we're in a very interesting time, particularly just in thinking about what the public is and what a healthy public looks like. But I don't think these movements are, there's any risk of the medical freedom activism losing steam.
My very next question was actually going to be about the measles outbreak and RFK. So we're very much on the same wavelength. I appreciate that you were able to connect those dots without any prompting even. Switching gears just a little bit, I was wondering if we could talk about women's right to reproductive freedom and how that topic maybe presents some contradictions in how people think about health libertarianism. Is it accurate to say that many of the same people who are vehemently opposed to government or other institutions imposing vaccine requirements, for example, because they believe that infringes on people's personal liberty, are actually in favor of the government imposing restrictions on women's reproductive autonomy? And if so, how can you help us make sense of this apparent inconsistency?
Yes, this is fascinating to me. I taught a class last spring called Conservative Political Thought. I taught it for the first time, and it was a trial run. And I designed that class to kind of satisfy a curiosity on the part of students who wanted to learn more on my own behalf. I teach a few days about conservative political thought in my Intro to Political Thought class, where we're going pretty quickly through ideologies. But it was a time to step back and unpack it in greater depth. And it was an interesting time to be doing that. I had about 20 students, and they were great. They did lean conservative in the class, which is totally expected and appropriate. And we had some really good discussions. And I will say abortion was the elephant in the room that I structured the class to really kind of bracket in a way, because I wanted the class to start out and be a very boring intellectual history. I wanted us to really get bored before we got feisty. And also use that time really to build a community in the classroom, to build trust between the students and me and the students and each other. And so, we danced around that topic some. At one point, it came up in a discussion, and a student from Florida, a white male student from Florida, said, "Look, states' rights. If you live in a state without abortion, then just move." And the conservative women in the room, many of whom I knew were not pro-choice, bristled at that. They didn't like that. That felt like a really kind of maybe a glib thing to say. And so it was interesting to sort of see that internal dynamic among conservative students. But later in the class, when we got to the topic of talking about some of this stuff, one of my students said, "My body, my choice." It was not about abortion. It was about some other health freedom altogether. Vaccines, I think, is what we were talking about. It might have been something else. And I said, and I paused and I looked at the other women nodding, and they're nodding, "My body, my choice." And I said, but abortion too? And they were like, "Oh, no, no. I was like, okay, so how does it work, right? Because on its face, it appears to be like a patent contradiction. I think, you can make it work logically if someone says, well, it's not just your body. That's another human being, and life begins at conception, and we all agree, and that's murder. And so that's, I think, the logical process you have to agree to make this work out and be internally consistent. But I don't think a lot of people have thought that closely about it. I also don't think those are sort of basic premises many people agree to. I mean, the discourse on abortion rights in this country and the public opinion polls on abortion rights in this country are wildly out of step, right? It's very clear that there is broad support for at least some access to abortion. And, that might be very minimal. It might be much more extensive, but the numbers do not reflect the public discourse, which is that we are absolutely divided, and I have an absolute right to do everything with my body except that. So I think it's a big mess, really, and I don't think it's I don't think it's internally consistent, but I think it's fascinating to see the way My Body, My Choice has gotten appropriated from feminists. And, there has been an internal critique among feminists of My Body, My Choice, because it makes choice seem like the route to control. And what, some feminist critics say is like, yeah, we want reproductive rights, absolutely. But pretty much no one chooses an unplanned pregnancy. That's not how it works. So there's already this lack of choice, in the context of which choice becomes this guiding virtue. So I think it's messy across the board, but I have a hard time squaring My Body, My Choice with, but not your choice on this one issue, which I've deemed as not a choice.
I guess we'll have to continue to try to figure that one out. When you visit UNE, you're going to present a lecture titled Viral Times, Health Libertarianism in the Age of COVID, and it'll obviously draw from many of the topics we've discussed today. I was wondering if you could just tell us a little bit what listeners should expect, who should attend, and why, just more broadly, is your topic and this work that you're doing, why is it important and relevant to all of our lives in these modern times?
Yeah, so I try to write talks that anyone could learn something from. So I think anyone should come. If you have a body, you should attend. We all have bodies, and so I think anyone can stand to think differently or, in interesting ways about their body. I think a lot of what I've talked about here will come through in the lecture, and thinking about in what ways is the body a problem politically, and in what ways might we do things differently to sort of address that quote unquote problem. And then I always ask listeners to think with me on questions that I'm still working through. So my general approach to giving talks is to talk more from my teacher hat than any kind of authoritative knowledge hat, and think with the people in the audience and hope that we all come away learning something, myself included. And so I think that's the flavor of the talk I will give. Also, I use, as I was talking to you before we started, I use a lot of slides. Some of them are horrible, and that's great. I've learned that sort of the weirder my slides are, the more my students tend to pay attention, because they're like, does she know how bad these are? And I'm like, oh, I do know. And you stick around just to see. So I think there's something to be said for a horrible use of PowerPoint. And that would be something that people who attend the talk would get to witness as well.
Well, I'm on board for a horrible use of PowerPoint, so I can't wait. Sara Rushing, I've really enjoyed learning more about your work today. Thank you so much for taking some time to sit down with us.
So much. I look forward to seeing you in Maine soon.
That's it for this episode of Oh, the Humanities. As always, thanks for listening, and feel free to tell us what you thought of this conversation on the CGH social media channels, Facebook, Instagram, LinkedIn, and X.